I'm saying goodbye.
So say hello, guys. That's Kathy Costello, and I think Doris is hiding here somewhere.
She was up and then disappeared. There she is. All right.
And I know Uncle Bobby is going to be on in a minute. I specifically sat in this spot because I wanted Bob to see the building he's going to be staying in when he comes here to give grand rounds the end of November.
Oh, fantastic. Very nice.
Oh, Teresa.
I just wanted to do the Brady Bunch thing. I'm going to hop off in a minute. I just wanted
Hey, Josh.
Very good,
man. Come on.
Sorry.
That's in case you guys don't know, Josh Katz, his illustrious.
They're not any better.
And is Ellen going to join us tonight?
She
Ellen
is
is on.
in the program tonight, so she won't be able to be here. But she gives her regards. Sends her
Excellent.
regards. All right, though, that's enough of me.
Yeah. Sorry? We have finished that?
Okay, we have another minute or so. Looks like we have a pretty good
Okay.
We do.
good
It's,
people there on. Let's see. We have, oh, there we go. Mila, we've
Okay.
got the Virginia contingency. We got Mike Racky on, my identical twin.
No, 12
And,
total.
Mutton Jeff, yeah.
Yeah, that's what I said.
Leora, Esther, Ellen Mowry.
It
Hi,
just is
Ellen.
stopping and going to 60. Starting back from
In preparation to get started, we do have some
giving it after
background
his.
noise, so I would ask everyone to please
No, I
mute
haven't
their
seen it
lines
yet.
unless they're presenting. I'll just go ahead and mute everybody.
Doris, you want to repeat that again?
Please do whatever you can to keep background noise to a minimum. So if you are not asking a question or presenting, please make sure that you mute your lines, please.
Right. And questions can be asked both by interrupting on the audio, or you can type the questions down below in the chat box.
And I am
And,
monitoring those. Yep.
And you're monitoring, and that's part of my job to field those. Uncle Bob, if he gets on, I think he will be here soon.
great. I'll go ahead and give some introductory comments just from the society.
Go ahead,
just so
that'd be
we
great.
don't waste
That'd be
any time while people
Wonderful.
are still gathering. So if you could mute the
Hello.
rest of the lines again, Doris, that'd be great. All right, welcome everybody to the 2019 to 2020 edition of our Clinical Fellowship Difficult Case Call series. Wow, that's a mouthful. And this has been a remarkably successful endeavor. And I must say it is thanks to three people that I'd like to call out as we get started. And I would like to call out a duo, and that would be Elliot Froman and Teresa Froman, who have spearheaded this for the last several years. And it has grown and become really, I think, important as part of the Clinical Fellowship year. And with the added feature and addition of their remarkably hard work and collaborating with the fellows and mentors to have several of the cases published in the Neurology N2 Journal. And we have just heard, and I don't even think Elliot knows this, we have just heard that the Consortium of MS Centers is going to welcome us for a symposium for our clinical fellows at their annual meeting in Orlando next year. And so that's also very exciting.
Oh, congratulations.
News. Yeah. And so the other person that I'd like to thank, you just heard admonishing everybody for their background noise, but that is in fact Doris Lill. And Doris works for the Society and has been instrumental in making sure that these calls actually happen and getting the word out to everybody and getting everything organized, changing dates when we need to, and just all around been the manager and leader of this call series. And so thank you, Doris, for all of your efforts.
Thank you.
And thank you all for joining us. I'm not going to spend a lot of time. This has been an exciting series that we've had. I look forward to this year, and I look forward to tonight. This is something a little different that we're going to kick off the year with a series of shorter cases, but I think just as informational, just as important. And so with that, I'd like to turn things over to Elliot Croman for his
Elliot, this is Bob. I had to come in on the phone for some reason. I've been on for a while, but it doesn't pick up any other way, so I'm on. And can I ask one quick question, Elliot? Or Doris,
yes.
Kathy or Doris. Are we switching to this Tuesday, or are we going back to our traditional second Tuesday? My assistant wants to know.
The rest of the schedule will be our traditional second Tuesday.
Okay, thank you, Doris.
You're welcome.
Yep. This was just moved because of the holiday schedule. So, Kathy, I think you pretty much said it all, except I do need to underscore the role that not only that the National MS Society has played, but Kathy Costello in particular. This program really was born out of a vision that she had with respect to this. And we also have to acknowledge and underscore the role that Scott Zamville at UCSF has played as the deputy editor of neurology and to neuroimmunology and neuroinflammation, but in also working with the editor-in-chief, Joe Dalmo, to get approval for a special section for the fellows. The best of the fellows who have presented the webinars have been invited to translate those into submissions of peer review case reports, and they're larger in length and have more data. So we've been extremely fortunate to have the support of Joe Dalmo as the editor-in-chief and Scott Zamville, who's also seconded as the co-editor-in-chief, Teresa and I, and now had 4 of those publications. And as many of you know, participating faculty on these calls are also asked to participate in the process of revision, writing, and really helping to mentor these fellows to get the papers in. I think it's been fabulous. So tonight is a different program. It's going to be 6 cases. I know that the year we have so much going on in neuroimmunology that while MS was discussed, it certainly wasn't the topic during the year. And so part of what really gave birth to this program was an attempt to really have a bit more telescoping on diagnostics, imaging, but also disease-modifying therapy and symptomatic management of what still continues to be the largest corpus of patients in neuroimmunology, which of course in the central nervous system, which is multiple sclerosis. So for that, we're going to turn to our title for this evening, which is Rapid Fire Vignettes. My wife, my better 70s, has a cowbell. She has instructions to ring it when we're somewhere around 15 minutes. And tonight's first case is going to be they're all going to be presented from the Department of Neurology and
Elliot?
our multiple sclerosis.
Elliot?
Yeah.
Can I interrupt? Yeah. I'm just going to say I'm going to give a 5-minute warning, and then I'll ring it up. So you'll hear a little bell at 5 minutes, and then at the end you'll hear 15. At 15, you'll hear another one.
Very disturbing cowbell, right? So all the cases are going to be from the Multiple Sclerosis and Neuroimmunology Center at the Dell Medical School here at the University of Texas at Austin. I know Mike Rackey's on the phone. So Mike, you heard me say the Dell Medical School at the University of Texas at Austin. A little inside Ohio State University. Yes, you. So we're going to begin with our first case delivered by Esther Melamed, clinician investigator at our unit and fabulous clinician, thinker. And Esther, I'll let you take it away. Those of you who are on camera, you can either go off camera, stay on camera, and remember, you can either ask questions audio or write them in the chat room. So Esther, you're on.
Just a second.
Hi, good afternoon. Can everyone hear me?
Yes.
Yes, very well.
Yes. Okay, excellent. And we're doing 10 minutes or 15 minutes, just to confirm. Teresa, are we doing 10 minutes or 15? 15. Okay, excellent. So thanks so much for having me, and really excited to hear everyone's cases tonight. What I wanted to focus on was something that we don't talk about often, but it's really the life cycle of diagnosis, and in particular focusing on elderly patients with multiple sclerosis, and what are the screening aspects that are important to do in our elderly patients. Can we go on to the next slide? We have a 78-year-old right-handed male with history of multiple sclerosis who presented to clinic for an initial evaluation and management of multiple sclerosis. His history began in 1978 when he developed first neurological symptoms. He had right leg numbness at the time with electrical signals in the right leg, and this was following flu. In between 1978 and 1992, he progressed with difficulty with walking, and he had imaging done and was given a diagnosis of multiple sclerosis. Between 1992 and 2019, he was treated with a number of different disease-modifying therapies, including beta-seron, Copaxone, Novantrone, methotrexate, and most recently T-cell vaccination trial at Baylor. His current functional status is he's wheelchair bound. He has urinary and bowel dysfunction. He uses in and out catheterization, and he manages symptoms with intermittent fasting diet and ketogenic diet. He has not been on DMTs for at least 7 to 8 years at this point. His past medical history is significant for hypertension, diet-controlled diabetes. He's got a polyp on colonoscopy that was found 4 years ago, and history of basal cell carcinoma. Surgical history is significant for a bladder stone that was removed in 2018. His family history is significant for a father with diabetes and an MI. Mother had strokes and was a smoker. No history of autoimmune diseases. He is currently on vitamin D supplementation of 2000, metformin, naltrexone, and triamterene hydrochlorothiazide. And on exam, he was generally very pleasant. He was very inquisitive. He was alert and oriented, with intact language, memory, and attention. And we can go, actually, if you could scroll through the entire exam, that would be helpful. He had intact cranial nerves. The main abnormalities on his neurological exam were on motor exam. He was weak on finger flexion bilaterally and had weakness in his bilateral lower extremities with some mild spasticity in bilateral lower extremities. He also had decreased sensation to all modalities in the lower extremities, and was ataxic bilaterally, a little bit worse on the left compared to the right. And he had hypoactive reflexes throughout. He was wheelchair bound, as he has been for several years. So on prior imaging, evaluation, he actually did not have imaging for at least 15 years because he had not had any discrete relapses, and it had been decided not to image him. And so after seeing him, we had discussed that it was important to get some cancer screening because he had been exposed to Novantrone and methotrexate in the past and had not had any imaging done. So we obtained MRIs of the brain and cervical spinal cord, which demonstrated some supratentorial lesions as well as C2-3 and C3-4 lesions on his cervical spine. And then, interestingly, on the thoracic spine, if we can go to the next part of the slide, please. On the thoracic spinal cord, he was noted to have some abnormalities, including abnormal signal at the posterior right fifth rib and within the right T5 transverse process. So these findings led to follow-up testing to try to figure out what were those lesions on the MRI of the thoracic spine. And on CT chest, abdomen, pelvis, he was noted to have some calculi in the bladder and in the kidney, but most concerning was a moderate prostate enlargement elevating the base of the urinary bladder. His bone scan came back with metabolically active rib lesions, and his PET scan demonstrated FDG uptake in the transverse process at T4 and posterior right fifth rib that were consistent with metastasis. He also had an enlarged pelvic lymph node. He had follow-up testing of the MRI, and the MRI unfortunately demonstrated a large prostate tumor that was replacing the right peripheral zone from the apex to the base, extending into the rectoprostatic angle, as you can see on the picture here. And follow-up biopsy demonstrated stage 4 adenocarcinoma with bone emets, which was what we were seeing on the T-spine MRI.
I'm going to pause for a question that just came in through the chat box from Joshua Katz. Where is he living? What kind of help does he have? And what is his quality of life and emotional status?
Asymptomatic. This was picked up just because we decided to do screening based on his history. He's married. He is one of those people who love life and who love learning about everything. He does a lot of research in terms of reading papers and asks a lot of inquisitive questions. He's really a very pleasant gentleman.
Okay.
So the treatment plan, and let's back up. Yeah, perfect. The treatment plan that, so he had seen, he was referred to see oncology, and they recommended chemotherapy with Lupron and several other agents, and the patient decided to decline chemotherapy. Instead, he decided to work with an integrative oncologist and to use off-label medications, including repurposed pharmaceuticals like atorvastatin, hydroxychloroquine, and metformin, known for their anti-inflammatory potential. And he's actually going to be coming in to see us soon. He has sent in a message through the portal asking to focus his next visit on initiation of therapy for multiple sclerosis. And of course, this brings up there's a lot of questions in terms of how to treat a patient with the diagnosis of cancer. The important aspects of this case, and again, we can probably spend an hour discussing this patient and all the aspects of his diagnosis and his care. But the important, the salient points I wanted you guys to take away from this case is that it's really important to remember that even though we have access to disease-modifying therapies today that have a side effect of cancer as a rare possibility, exposure to prior agents such as methotrexate for this gentleman or cyclophosphamide as the initial immunosuppressive therapies that we've had prior to the advent of the more modern DMTs do carry a higher chance of cancer. And it's really imperative in elderly patients, especially where there's a higher chance of the possibility of cancer, to evaluate the medications that they've been on and to offer optimal screening, age-appropriate screening. That should also be a given for any patient of any age who has a family history, a strong family history of cancer. It is very interesting that cancer risk in MS patients is actually same or lower compared to the general population. But there are some cancers that are higher in the MS patient population, including urogenital, CNS, and skin cancers. And so it's very important to pay particular attention to those types. And there are no current guidelines on how to manage patients with MS who have a history of cancer. And we can go to the last point on this slide, that it is interesting that many disease-modifying therapies have been studied as cancer therapies. So for example, in this gentleman's care, some of the considerations may include medications such as Gilenya and Aubagio, that have been specifically studied in prostate cancer and several other cancers, and should be considered in a patient like this. These decisions are very challenging, and again, there are no clinical guidelines. All of these decisions need to be made on a case-by-case basis. And in some patients, we may opt to start someone on a medicine that doesn't have any associated cancers, which is very few DMTs at this point. But this needs to be a discussion that includes a good understanding of the mechanisms of action of different disease-modifying therapies and their potential for causing cancer versus treating cancer.
Esther, do you have a follow-up in terms of what this gentleman, what you and this gentleman decided to do going forward, or are we still in that process?
Yeah, so we have not yet had a chance to meet with him following the completion of the oncological workup, but he will be coming in soon, and he had sent us a message through the portal saying that he'd like to discuss therapy of MS in context of the cancer diagnosis and treatment, so that will be the focus of his next visit.
Well, that was a lovely presentation, and I think that keeps us on time.
Could I one or two comments, please?
Yes.
First of all, watch this elderly stuff, Esther.
Yeah, that's only information in excess of 100.
All kidding aside, you could argue that his risk at 78 for having prostate cancer had nothing to do with his MS or his previous therapies for MS. Second thing is the only approved therapy for DMT that works in cancer are the anti-CD20s, and they work in B-cell leukemias and lymphomas. So patients have to understand that. There was a recent presentation of European Neurologic Society, whatever they're called now, that they did have a higher incidence of cancer, including the ones you mentioned, urogenital, CNS, I think skin, and then interestingly, they thought there was a higher incidence in lymphoproliferative in family members, and how you want to deal with that, it's all speculation. But I don't know if we are supposed to screen people of certain ages who are asymptomatic. As you know, prostate is probably the most controversial about whether you should screen people, even if there is a family history and over certain ages. So just raising these things for us to think about, which are important independent of the MS.
All very important to consider. The body is connected, and it's none of the diseases are in isolation. So as MS clinicians, we really have to think about all of these important issues. Thanks for the comment.
One of the prior slides, Esther, you had just mentioned the statin, and we happen to have on the line Scott Zamville, who did a lot of work on statins and their effects on inflammation, and particularly MHC class 2 activation. And in fact, I think one of the articles was at the front cover of Time magazine or U.S. News and World Report, Scott.
Newsweek.
Newsweek. Newsweek. Yeah, for the really young fellows on the line, could you just give us maybe a couple of sentences on why Esther brought up the statins and what's our current thinking in terms of their utility or placement in immune-mediated diseases, if at all?
So, boy, I want to reverse that, the if at all. Yes, there is a rationale for using them, even today, even though our trial did not make its primary endpoint that we had positive results. The idea of the cholesterol-lowering statins is that acting through pathways, intracellular pathways, directly on how they intermediate of the cholesterol synthetic pathways have a critical role in immune modulation. And our work in 2002 demonstrated for the first time that that statins cause T-cell immune modulation, and we did that in all the EAE models, and that led to testing them in other autoimmune conditions. We didn't make it in our CIS trial, and currently in the UK, they have found benefit in a phase 2 trial that was in the Lancet a few years ago from Jeremy Chataway, where they showed there was a benefit on reduction of atrophy and disability progression, and simvastatin, which they used then, is now in a phase 3 trial. So there is some rationale.
Yeah, and I happen to have not just Scott, obviously Scott Zamville has been a regular fixture of our program, but we have Mike Racky on the line, and it's too tantalizing not to ask Mike about, particularly Esther, you very beautifully point out the convergence or concomitant disorders, MS, advancing age, cancer, but we're talking about a patient with diabetes. Then, Mike, any comments about diabetic drugs that might actually be repurposed, used in immune-mediated disorders, the PPAR drugs or others? And for those of you who don't know, Mike is the editor-in-chief of the Journal of Neuroimmunology and was with Teresa and I at Dallas before Ohio State. And like Scott, is one of the premier neuroimmunologists in the world. Mike?
What? Hello?
Yes, we hear you.
Okay. I lost audio there for a second. I went to the phone.
Oh. I was asking the question about in a patient that has concomitant disease, MS and diabetes, talking about potential role of PPAR and other drugs, where we might be able to treat two disorders and repurpose older drugs in order to cover both disorders or have effects in both disorders.
Yeah, well, there was a company that did a study in Russia, actually, having redesigned a PPAR gamma agonist that did not have the cardiac toxicity of like rosiglitazone and some of the other diabetic medications. And they showed like a 50% reduction in gadolinium-enhancing lesions. And the interesting thing is that all those patients were vitamin D deficient, and if they had had supplementation of vitamin D, those two things happen to be linked, that might have actually improved the efficacy of the PPAR gamma agonist. So
I did not know. Very interesting.
A lot of
Thank you for that, Mike. So Teresa has just informed me we're 3 minutes over, but I haven't heard the cowbell. She's being very nice. So I think we're going to transition now from Esther Malame.
Because we actually have questions in the chat box from fellows. So let's make sure that we.
Okay.
Yes, we do. So Kristen Crisco wants to know, can you elaborate on particular DMTs that you feel comfortable within the setting of a history of cancer?
Esther, I think that was for you.
So in terms of therapies, so I mentioned that Gilenya and Abbagio have been studied in prostate cancer, as was also mentioned. B-cell therapies are therapies that have been applied in treatment of cancers, were originally studied in cancers. In different types of lymphomas, and many of the other drugs, many of the other DMTs have also been studied in different types of cancers, both in vitro, in vivo studies, as well as in current clinical trials. Copaxone and interferons are probably the drugs that have the least association with cancers, and so those potentially would be higher up on the list in terms of offering to the patient if he needed to be treated at this time. But of course, optimally, a discussion will ensue where we discuss whether the patient really needs to be treated at this time, given the progressive nature of his symptoms over time.
Sorry to interrupt, but I know time is really getting shorter, but that does relate to the question by Nita Zargami. Does he have active MS? Does the benefit from DMT versus no DMT, regardless of his history of cancer, given his age? So the question they're asking there is, I would imagine, is based on this guy's age, does he really have active disease? Should he be on treatment or not be on treatment? Doesn't matter.
That's right. And so each patient has to be considered separately. And in this gentleman's case, he's had a very progressive course of his disease for a long time. And we may not necessarily put him on treatment at this time.
Yeah, but remember that there's always more to lose, always more to lose. And one last comment, Ellen Mowry sent a message to the doc. She wants to make a comment. So Ellen, chime in. We'd love to hear your voice.
Sure, I had the same, concern to consider about benefit and risk ratio. And because the patient it sounds like, is perhaps not pursuing mainstream therapy for his prostate cancer, I do wonder, and then is focusing on I need to get back on an MS therapy. I do wonder, if he's really processing his cancer diagnosis correctly and the relative seriousness of metastatic cancer compared to the, the relative seriousness or treatability of his MS at this time. So if you have a relationship with a patient, it's always nice to use that long-term relationship to sort of explore how the cancer diagnosis is being absorbed by the patient.
And
then another time we should really talk about what to do in young people who are on their MS-DMTs, who are going through a flog of chemotherapy, and what different approaches people take. But I know we're over time.
Well,
that's right.
You.
That's really interesting question, and would love to chat more about it.
Yeah, and by the way, as Esther said at the beginning, he may be asymptomatic now, but with disseminated disease and predilection for places that can create a lot of havoc and discomfort, like bone mets, I think, Ellen, your comment is extremely important, because today is not necessarily, and in fact, it often is not a predictor for tomorrow or next month or next year. And so I think you do have to look beyond the end of your nose and how you feel today. And I wondered the same thing. Is he really processing and putting this together? And I can't think of anybody better to counsel and have that discussion than Esther. But if it wasn't Esther, the next person I would think of that could be as good as anybody in the world is Leora Freeman, and she's going to present our second case related to a really important issue as it relates to new diagnosis of MS during pregnancy. Leora?
Can you hear me?
Yes.
Yes, you're coming across fine.
Awesome. I don't know how to. Yes. Okay. So,
Leora?
Hello.
I'm sorry to interrupt. This is Teresa. Before you start, because there may be a lot of questions for these vignettes that are not getting to. If the people who are presenting the vignettes see a question on their side that's directed toward them, please, you can go ahead and answer that while you're listening to the current vignette, but you can answer that offline to that specific person.
Great point. And Leora, maybe before you jump right in, some people may not know that Leora joined us in the MS and Neuroimmunology Center at the Dell Medical School at UT Austin, starting just this past June. So she's certainly not a newbie to the field, but she's our newest recruit here, and we are just thrilled to have her. Leora?
Very glad of it. Thank you, Elliot. So presenting kind of at the other end of the spectrum, but similarly to Esther, kind of a case where there's been we've had a lot of discussions internally about how to manage this patient in this very peculiar situation. So this is a story of a 27-year-old female who is currently pregnant with her second child. When she came to see me in the clinic, she was at 20 weeks plus 2 days, and she had just recently received a diagnosis of MS. She doesn't have a very elaborate past medical history, but she did give birth to a son over 16 months ago. And during that first pregnancy, I tried to dig a little bit about symptoms that she had during that time. She only reported some migraine, some poorly defined floaters that would get worse while sitting in her third trimester. She did describe some right hand and foot numbness, but that would come and go. She was uncertain about the foot location, but the right hand was a definite. I thought that she may have had carpal tunnel because she also described pain in the wrist and the hand on that side. All of her symptoms went away as soon as she had her baby, per the patient. Her son was in the NICU for some time, and she did pump breast milk for about 4 months. What I found interesting was that she was one of those women blessed with profuse production of breast milk, and her body didn't really stop, even though she stopped pumping. Her body didn't stop producing breast milk until a few weeks prior to this recent event that we're going to talk about that occurred at the end of June. If you can go to the next slide. So her first neurological symptom that she reports occurred around week 16 of her current pregnancy. Noticed, again, tingling and numbness in her right hand and her right foot. She talked to her OB-GYN, who said, oh, it's probably your pregnancy, weird sensory symptoms and things like that. But within a week, her symptoms involved the entire right side, and she became scared when it started involving the right side of her face. She presented to our local hospital where she was admitted. She had an MRI of the brain and spine. She had some blood work, and she had a lumbar puncture. So I'm going to show briefly the outside imaging. If you can go to the next slide. And so briefly, we can see here that this is a patient that presented multiple abnormalities visible on the T2 FLAIR sequences, with abnormalities present in the periventricular area, in the juxtacortical area, and infratentorially as well. We do not have injected scan as this patient is pregnant, but the lesion looked relatively consistent with a potential diagnosis of CIS suggestive of MS at that time. You can go to the next slide. The patient had extensive lab workup, particularly autoimmune workup, infectious workup. She had a CSF analysis that, you can see it in red, the important results, the presence of 7 oligoclonal bands not found in the serum. You can go to the next slide. The patient was given a diagnosis of MS, and she was told to follow up at our center. At the time, and I assume based on the sensory nature of her symptoms, she did not receive IV or oral steroids. By the time she presented to the clinic a couple of weeks later, she saw Ashley Lucas, a wonderful PA, for her first visit, and then she saw me a little bit later. So we did have some back-to-back visits with her, which was great to address all of her questions. You can go to the next slide. By the time she got to Delmed, she reports that her patients have significantly improved to the point of, being very extremely intermittent tingling in her hand. Her neurological exam when I saw her was normal. But the important part that I wanted to present today was the discussion that we had on her plan of care during pregnancy, and also the risk and management of her MS in the postpartum period. Next slide. So to be able to, this is to answer all of these questions, because this is a patient for whom we do not have a history prior to pregnancy. We don't really know what her disease is like prior to this event, but it's very significant that she had a neurological event in the beginning of her second trimester. We overall tend to say that that pregnancy is beneficial to MS. This is particularly true as we enter their third trimester with a 70% relapse rate reduction during that time, which is, as good as our top drugs. But some have described that the relapse rate in the first or early second trimester may be even increased. So it is important to know that people can have relapses during pregnancy, and certainly we can make a diagnosis of MS during pregnancy. So the first question that this patient had was, what if I have another attack? What can we do? And we explained, as our fellows know very well, that steroids are generally considered safe during pregnancy. We do have to, still be cautious when using high-dose steroids, but in this case of this patient, it was not. I would agree that it may not have been indicated considering how mild and sensory the symptoms were, but we can have very significant relapses during that time, which may require sometimes even more than the steroids alone. And in these cases, IVIG may represent a safe second line for management of these attacks. The question for this patient was, what else can we do during pregnancy? And we discussed DMT. She was really not willing to take anything day in and day out, as she was concerned for the health of the baby. We did, however, review some of the data that we have. We do know that there's currently no approved choice by the FDA for the treatment of MS during pregnancy, but we do know that, for instance, glatiramer acetate has been the only FDA Category B DMT that we have. I have personally extensively used it in women that were on Copaxone prior, remain on Copaxone throughout and throughout breastfeeding. We know from the branded Copaxone data that there are no risks of congenital malformation, and my personal experience has been very positive with this drug. Interferon has been classified as a class C, no evident risk of malformation, but a minimal increased risk of miscarriage in some studies. But we do know that sometimes some of our patients need a little more, and natalizumab has been in some cases what some of us have had to weight the risk and benefit for. We do know that there's a slight increased risk of malformation with this drug from past studies. It has been across the globe kind of used in the third trimester, sometimes in aggressive MS, and it has sometimes been associated with hematologic abnormalities in the offspring. We do know that it does cross the placenta. If we can go to the next slide. So, and we'll address the questions from the fellow. I see something from Nita. I want us to have a discussion a little down the road. This patient, as I said, was not really in favor of any therapy at this point. So we decided to discuss DMTs in the context of the postpartum period, but that was contingent on an important fact, whether or not she would be willing to breastfeed her child, and for how long. One of the things that I explained to her is that unfortunately breastfeeding doesn't appear to provide sufficient protection from relapses, and that it's, there's not enough protection to warrant not restarting DMT shortly after birth in women with active relapsing disease prior to pregnancy. We did not have that information in this patient, so we had to really discuss, okay, what are we going to do? And this is based on what she wants to do for her child and what tools we have at our disposal to try to prevent relapses, whether or not she chooses to breastfeed. So we know that there's an increased risk of relapse in the postpartum period. We know that sometimes patients may be more active than in the year prior to pregnancy. It is important to remind our fellows that steroid use is generally compatible with breastfeeding. Usually we can use IV steroids and recommend 2 to 4 hours between infusion and the next feeding of the child. It does pass in the breast milk, but the passage is relatively small. So a waiting period is by most OB/GYN recommended rather than just pumping throughout the 5 days of treatment. We do not have extensive data on DMT excretion in the breast milk. It appears that some of our DMTs have a small molecular weight and are likely to transmit through the breast milk, but molecules such as GA, rituximab, or interferon beta may have a large enough molecular weight to have an unlikely or minimal transmission. The point that we discussed with her, because she breastfed her child for 4 months, personally, this is a patient that had a relapse during pregnancy. She had lesions who were relatively large in size. We do not have contrast enhancement, but I would assume from the aspect of those lesions that there's some pretty significant activity. I think that if this patient chooses to breastfeed her child, we ought to offer something to try to decrease her risk of postpartum relapses. And the discussion that we had within our group was the indication of IVIG immediately after the birth and on a protocol 4 weeks as long as she desires to breastfeed. So reviewing a little bit the literature on IVIG in the postpartum period, it is indeed something that can be considered safely in women who want to breastfeed and are thus unable to start or restart DMTs. It seems that though it seems to be efficacious to decrease the postpartum risk, it may not be sufficient to decrease the postpartum risk of relapses to pre-pregnancy levels. But this is certainly something that we can do, and most protocols recommend an initial course in the first week postpartum, similar to what we all use in the general population, and with booster doses every 4 to 6 weeks, depending on the studies. So for this patient, we have she's currently still pregnant. She's doing well. We sat down for a couple of hours and discussed really our options. She is torn between wanting to breastfeed but wanting what is best for her MS. The level of evidence for restarting DMT shortly after giving birth is higher, than the level of evidence for IVIG immediately following birth, but we presented both options to her. I think that this is a patient that will likely go to something like Ocrevus post-pregnancy to be able to navigate potentially further, later pregnancies if she wishes to. If she chooses to breastfeed, we will definitely have an IVIG protocol for her. So I wanted to leave this up for discussion and just, wanted to hear everybody's experience using IVIG and everybody's opinion on the question.
Thank you, Leora. That was great.
Greg, did you have a question?
Yeah, we have to be honest. The evidence for IVIG in MS in any stage is pretty weak. I mean, it may be safe, but the evidence that I know people use it, but it's really meager. And so you have to think about that during the pregnancy and postpartum. And remember that during the pregnancy and immediately postpartum, patients tend to be more hyperviscous and more likely to clot. And when you're giving IVIG, you could theoretically cause placental infarcts, all sorts of stuff. And I was saying there's evidence that it happens a lot, but think about it given the weakness of the IVIG data. One thing about patients going into pregnancy or planning it, in theory, if you used ocrelizumab or rituximab, you could lower the B cells for 6 to 8 months, and the actual monoclonal antibody would be out of the system by maybe 2 months. So you wouldn't be affecting the baby's B cell maturation, and you would have the low B cells in mommy, which for some reason may help the MS. So there's no evidence that that's safe or that it will always work, but at least you get the monoclonal antibody is gone, and yet its effect is longer lasting, and then they become pregnant.
Mm-hmm. Yeah, the ocrelizumab, this is exactly what we discussed with this woman because she does want to have a third child. I do think that this is an appropriate strategy to manage future manage her MS in the context of possible future pregnancies. But the question, so what do you propose, Bob, to your patients in the postpartum period if they do choose to breastfeed, or invite patients to
well, if they're on glutathione acetate, you can't find it in the blood or the milk because it's processed by the lymphocytes and monocytes locally. I put it to them that I think that they have to strongly consider not breastfeeding. Some of them will do it, but I would offer IVIG, but with letting them know that I'm not sure that this is the best thing for them. And if it's not good for them, it may not be good for the baby, because the baby eventually needs an intact mommy when both are older.
Yeah, absolutely agree with you. And this is a term that I've used for this patient. This is that the evidence of restarting DMT after birth is much stronger than the evidence of IVIG. That if she chooses to breastfeed, we will propose an IVIG protocol to her. I'm, seeing her next month, so this is when we're going to be kind of making decisions for that. But yes, I think that this is important to highlight that the evidence that we have for IVIG is anecdotal or weak. The evidence for DMTs is much stronger. However, it remains a period of time where choices are made by women that have to be supported.
Absolutely.
So, Elliot, I wanted fellows to hear your experience with IVIG.
Well, good. I'm glad that we brought that up because, one, I completely agree with Bob with respect to the available evidence, the class of evidence and the recommendations for your broad statement about application of IVIG in MS for anything. However, the absence of evidence is not evidence of absence. And I do have a cohort of patients who have had tremendous difficulty with DMTs. Most of these agreeably are before the era of the emergence of the intensive oral and IV immunotherapies. And these are patients, they're always outliers. So the absence of a statistical effect in group B on IVIG compared to something else, you may not see an advantage or even non-inferiority when you look at this. But remember, we're looking at groups that are not clones. Like when we look at mouse models, this is an outbred strain. So there's no question I've had patients who have done it not only well, but when they've attempted to taper off, they have flared and then gone back on IVIG. The regimens vary. Generally, we're talking about 0.4 gram per kilogram, a 1-day infusion given, every 4, 8, or 12 weeks. That's for maintenance. My experience with postpartum has been similar to the few studies by Anat Akaron in Israel. And that is in the original studies, it was given at delivery, so 0, 6, and 12. Our regimen is much milder. We generally do it at 1 week, 7, and 13 for reasons, in part, at least what Bob mentioned about hyperviscosity, hypercoagulable state, a mom that doesn't need a headache in the hospital. So there we give only, again, a single day, 0.2 to 0.4 grams per kilogram per day, but only for 1 day at week 1, 7, and 13. And like her data, I've not had a single patient that's had a postpartum event defined by delivery to 6 months. But that's a clinical experience. It's germane to what we see, and part of what we see may be our own bias. I get that, but having done this for almost 3 decades, Bob's done it for longer, certainly seen innumerable patients with pregnancies, and I've certainly seen patients who have done nothing at delivery, and by the way, including what we might have thought was a low-risk patient. Caucasian woman, did really great. We were going to do IVIG. She was having such a good time with the breastfeeding. She didn't. And I think Christy may be on the line. This is one of our patients from Dallas who followed us here to Austin. And it was about, 6 weeks postpartum breastfeeding that she had actually one of the most severe exacerbations I've ever seen. She came in with a skew deviation and bilateral 6 with bilateral rubral tremors, scissored at the legs, immediately admitted hospital, steroids, and plasma exchange, and recovered beautifully. But I will tell you, radiographically, Leora can predict where a lot of the action was, and it was incredibly scary. But look, most of the patients that have postpartum attacks, we know even from Akaron's discussion in her papers, most of those are sensory, and most postpartum events between 0 and 6 months also tend not to move the EDSS very much. But the problem is, in the natural history era, we had patients not on DMTs. We knew who went into pregnancy and what their course may have been in the preceding 1 to 2 years. Today, you don't have the same luxury, and that's a good thing. We have patients on disease-modifying therapy, so you don't know how rock and roll that patient's going to be postpartum after they deliver that third trimester, great disease-modifying impact on MS. So there are still things we don't know, but I agree that the evidence is weak, but that doesn't militate against the fact that it may be appropriate and applicable in some patients. One little nuance is a patient I have who was having foot surgery and was having multiple skin abscesses and problems with her DMT, put her on some IVIG, all of her abscesses went away. She went through the surgery, no post-surgical anesthetic or other stress-related exacerbation. But let's also remember that IVIG is the universe of antimicrobial therapy, or in a sense that it is, but it clearly has not produced what we had hoped it would produce for us, as it has in CIDP and some other areas.
Last comment is that some of the doses that people are using in MS would be considered homeopathic in CIDP. I have maybe 20, 30, 40 CIDP patients, and those that need that little don't really need any. So it's hard to tell.
Yeah, very hard, and I would agree. My CIDP patients, when I've treated them over the years, much more traditional dosing in terms of the total of 2 grams per kilogram, whether it's over 5 days or 2 days. So in the interest of time, I think we'll transition now to number 3. I see Doris giving me.
Doris has a slide for us.
All right, let's go for the next one, and we'll move that transition over. Is it Ben Ehrenfeld, our
Elliot, before we do that, there was a comment in the box that wasn't addressed, and I don't know if we need to. It's okay. It's a comment from Johans in the chat box.
Notably CD19 therapy has been given throughout pregnancy in the rheumatologic literature. Babies do well, although have lower B cell counts without any weird infections reported. And Johannes, thank you for bringing that up. in general, as you know, with MS, pregnancy is incredibly favorable. There are outliers and there are exceptions, no question about it. And we've also had patients that did require therapy during the course of their pregnancy. And my first objective is to protect both patients, but if I have to choose, the mother trumps the baby in all circumstances. But that's quite right. People have been treated with a variety of things during pregnancy because they had to be treated. Obviously, we'd like to avoid things like plasma exchange, where we might have fetal placental insufficiency. And there may be other agents we could talk at some length at, but I think that's a very important point. Bob, did you want to make any specific comment about, CD19 or CD20 therapy during pregnancy? This is in literature.
I mean, it is used in rheumatologic where it's, quote, life-saving as opposed to what we worry about in MS. I would point out, though, I don't know how long-term follow-up of those babies with the slightly low B cell levels are when they're age 18. So, the long-term follow-up for offspring of women on various drugs is not 1 year's worth. And so I don't know if the rheumatology literature goes back that far.
Yeah.
Rituximab is only about 20 years old.
That's one of the most important comments we've had actually probably in the last year, and that is the spectrum of life clinics that follow kids with autoimmune diseases, but when they transition to adult clinics, we're sharing information and talking to each other. And I think one of the giant elephants in the room when you have the pediatric literature say X was fine when they left us, but there's a huge ascertainment problem in terms of, but what happens after that? 2 years, 5 years, 10 years. I see a lot of kids who were said to have monophasic ADEM at the age of 11, and then I see them with bilateral INO and a rubral tremor at 19 or 20, and multiphasic disease that's classic MS. So your point is very well taken. It's hard to know about anything except in the retrospectoscope, and you have to follow them to get that. So thank you for that, Bob. So with that, I think we'll go on and transition. This is Ben Ehrenfeld, who's our case manager, social worker extraordinaire, and he's going to present Bobby and the Big Ugly toward a biopsychosocially intersectional model of treating people with co-occurring DSM-5 presentations and multiple sclerosis. Ben?
Good evening, everybody. I hope that you can hear me, and I also hope that you will bear with the fact that I do have a stutter. It's not because I'm nervous. I've had it for a number of years, but hopefully it won't make this hard to understand. So I'm going to share a bit first about what I do in our center. I support the patients who come to us in overcoming the psychosocial barriers to care that can sometimes be financial. It can be other kinds of ambivalences that they might have. I get involved in supporting people's mental health. That involves doing psychotherapy or connecting people to psychotherapy in the community if it doesn't make sense for them to be getting that in-house, so to speak. And then, of course, supporting the team and ensuring that all of these different factors are accounted for in giving care. So what I hope to do this evening is just give you a snapshot of a patient of ours who had some significant mental health and psychosocial issues going on, whose MS was fairly stable, all things considered, but things could have gone very badly for him in that area if we didn't tackle some of these other areas. I'm going to talk about some of the various factors at play and how we managed them, and then to talk about a possible model to see if what we did is something that can be helpful in settings that aren't just our own. And the purpose of this is because care can be as multifaceted and holistic as the human life is if we decide to do it. So with that, we will talk about Bobby. Bobby came to us in February of 2017, 35-year-old single white male with RRMS. His symptoms began in 2016 with a right humerus hemophilia, which recovered. He had been on Tysabri, and at this time the conversations began to move to a transition to Lemtrada. And at that time, he talked about having some of the depressed mood and irritability, but it was not significantly impacting his life. In August of 2018, we discussed the possibility of accommodations at his job because of fatigue. But then in October, things came to a head where basically his supervisor said, "You're sort of you aren't able to do this, and you need to take some time off, or you're not going to have your job anymore." He was experiencing fatigue, anxiety, and very, very emotional at his job. And if he loses his job, he loses his health insurance, and this whole shift to DMT, or even getting his current DMT, would be a challenge. So I began seeing him for therapy on 10/9/2018, and at that point he talked about feeling completely out of control, and called MS the Big Ugly, who was chewing at his myelin, and that having MS felt like being on the other side of the barrel of a gun. So I'm not sure how many people can actually see, but I've got an image of the biopsychosocial impacts on Bobby. And if you see that if Bobby is at the center, you have disease activity and fatigue, anxiety, anger, an intense job, and depressed mood. All of those things are impacting each other. And it's sort of a chicken and egg thing. It's hard to know really where any of this started. And so we couldn't talk about, well, we have to manage this first and this other thing second. It became fairly clear to us as a team that we were going to need to tackle all of it at the same time. So how did we do that? So that comes next. So in terms of MS, in December of 2018, he had his first cycle of belatuzumab, and in April 2019, because of Elliott's low dose rituximab system of care, he had that. But if we go to the next slide, we'll find that we were able to do that because we supported him in taking time off at his job through short-term disability and FMLA, which meant that his job was safe and meant that he could keep his health insurance so he could have these things done. It also meant that he had some time to see me for counseling for an intensive period of time, and to apply those coping skills and such that we talked about in session having the anxiety of the day-to-day of the job. And so those are the things that we did in terms of accommodation and time off, and he started going back to his job in the early part of this year with some amount of accommodation. Elliot did manage some medication support. He had been on Wellbutrin up until October of 2018, and then Elliot started him on Fadsima beginning at 20 milligrams up to 40, and that's because Fadsima is a SNRI, which has been shown to actually have some help with fatigue also. He's actually since stopped taking Fadsima. That was not our particular goal for him, that he had to stop, but he felt it would be important. It was a goal of his to be able to manage and not be taking it, and he's been stable off of it since that time. So in terms of the counseling, I saw him for a total of 24 sessions, again beginning in October of 2018. Every Tuesday for 5 months. Then it moved to every other, and then just monthly for his final 2 months. So I did a sort of overarching introductory biopsychosocial assessment, and what showed up was that in terms of diagnosis, it was a moving target. It could have been a mood disorder, it could be anxiety disorder due to a medical condition with mixed emotional features, or it could be an adjustment disorder. And it's because that even in narrowing down the possibilities, some of the different criteria in the DSM, there were certainly overlap. An important thing to note, however, was just how traumatic Bobby found his first symptoms of MS in 2016, and his fear of those coming back really reminded me of folks who I've supported who have a PTSD and adjustment disorder. I think the fact that we sort of colloquially actually call an initial MS episode as an MS as an attack might give us all an idea about how it could be that somebody could experience this as a trauma. So because of that, in terms of my interventions, I focused on interventions that are evidence-based for folks who have trauma history, and also focusing on the sort of general coping that you might get with something like a generalized anxiety disorder, and that's where the motivational interviewing and a narrative therapy comes in. But I decided to blend my models because there was a blend of symptoms. So if we go on to the next slide, these are some things that Bobby said during our final session together. That he still has hard days, but that they only last for maybe a day or day and a half. and that he doesn't feel like he has a gun pointed at him anymore, and that the combination of the alatuzumab, the accommodation his job, and the tools that he and I focused on, he says that I have more control over what I do, even if I can't completely control the MS. So to the extent that our team and Bobby had an objective to help him improve his functioning, feel less anxious, and get the care he needed, this was achieved. But beyond that, a conceptual model to maximize the possibility that this could be done again that would maybe function in between similarly complex variables is, I think, beginning to be something that could be emerging, at least for my conception of our time in the center. And so if we go to the next slide, a full biopsychosocial assessment often shows that there are a bunch of different issues that can affect people. And so I think applying the idea of intersectionality to biopsychosocial care can be very, very helpful in terms of thinking about how MS clinics can ensure that all of the different pieces that enable people to access total health can be discussed and cared for. And so I think that having counseling and therapy, case management, and basic psychopharmacology, I think it's an important part of care for folks who have MS, and ideally, if it can be in-house in the MS center, all of the pieces can be thought about and taken care of in an appropriately intersectional manner. Because while the specifics of what was done in this case are important, I think it's the conceptual picture and the sort of intersectional care which Elliot is always informing us as being at the heart of what we do. These are the things that increase the possibility of success across all the different circumstances our patients and ourselves are found.
Ben, thank you so much. That was a beautiful presentation and on a topic that we rarely cover in this and many other contexts. So it's profoundly important, which is exactly why I asked you to participate. There's a question from Nicholas Lannon. As MS providers, in setting a narrative for our patients, is there a more advisable way on how to break the news of an MS or CIS, clinically isolated syndrome diagnosis, to a patient, or useful phrases that you might use or you may decide to avoid using?
I think the only thing I'll say to that, and that I'd love to hear what the actual MDs and PAs are saying, is that even if we don't call it an attack, I think people, especially if there's acute optic stuff going on, or if someone just gets up in the morning and can't move, it's going to be experienced as an attack, even if we don't call it that. And so I think that there is something about just understanding that even as people come on the other side of these acute symptoms, they have the possibility of having a presentation that is not dissimilar to somebody who who's been in a car accident or who has been attacked because they truly feel that their body just attacked them, or on the anniversary of their first episode. So I'll just say that to that point about the terminology, but I'm of course curious what other people have to say about how it's disclosed and how that's important.
I have to reel up it. I think that was great. But I think it's important to help the patient define what we mean in an attack versus what they mean from the point of view of planning their DMT. Because even with 14 drugs, let's assume the interferons are all about the same, you can run out if every time patient has prolonged symptoms, and you're not doing the patient any favor that way in the long run. And I think talking to the patient, as you point out, especially about with the original diagnosis, the late Labe Scheinberg, who's the patron saint of multidiscipline care in MS, pointed out that sometimes just somebody has to tell the patient, hopefully nicely, because otherwise they run from one doctor to another waiting for something else that isn't there. So, I mean, Labe had more experience than anybody with this, and also was in an era when he didn't have much else to offer people, and he felt that just giving them the truth nicely sometimes was an important thing to do.
Hey, Bob.
So that was a great presentation, Ben.
Thank you, Bob. That was great.
In the forward of Teresa's book in collaboration with the National MS Society, Teresa was commissioned to serve as the chief editor on MS for the physician assistant. There's a paragraph in the forward where she says, you know, it's not so much what we know or what we can do. The most important thing you bring to your patient is yourself. Now, this was not planned, but, and I'm not going to identify who it is unless there's agreement, but there's a very dear and longstanding patient of mine who can speak to that briefly if she chooses to do so. We have a patient on the line. She's also a therapist, by the way. But Ben, I think you're getting at something that's really critically important. Whether it's a diagnosis or a failure of a therapy or an adverse event, the key is never abandon your task, your mission, and your oath. Never, ever, ever quit. And you must always try. And I'm prepared for the question, what happens when you tell me you will always try, but you run out of things to do? And before Uncle Bob beats me to it, that's when you make things up, which is the code phrase for hypothesis-driven medicine. There's never, ever an excuse to say, there's nothing more that I can do. You can also ask for more time. You don't necessarily have to come up with it in the context of the clinic visit. But I think it's really important for patients to know that no matter what, you are never, ever, ever going to abandon them, ever. And I think that's a very important point. Now, it's 6 o'clock. I have this person on the line. If she wants to add something to that, that's the most authoritative voice we actually have is our patients. That's who we work for. And if not, then we'll transition to what I think is going to be our last for the evening. There were two more after the next one, but the discussion has been so great, I think we'll make the decision to save the last two for another time. One was going to be presented by Teresa, and the last one, probably not a shock for some of you, I was going to present the last in terms of heads and tails, pelvic floor issues, sexual dysfunction. So before we make the transition, yes.
It's Teresa. I just wanted to, again, say to Ben how precious and awesome it was to have him present this tonight, because most of these are always patient cases related to what's going on with the patient, how do we diagnose it, what are we going to do for it, and this was another way to fulfill the all-encompassing, you know, how we take care comprehensively for the patient, because the patient is a person, and you know, I'm just so happy that he decided to present tonight. Ben, thank you so much.
Yeah. And
thank you for inviting me. So thank you for inviting me to do it.
Not to mention the fact that we're also spoiled here because he is our premier case manager and social worker, and it's not just what he offers.
Even if he wasn't, I would say that. It was awesome.
He's amazing, and I think he makes us all better for his presence. So
Okay.
I think, Doris, with that, I think we'll go ahead and transition to what I think is going to be our last, and this is our fellow for this year, and it's Alex Cruz. He came to join us from LSU, where he was chief resident in both his junior and senior year. He's currently an MS Society funded fellow, and very proud of him. I was off to give grand rounds at Auctioner in New Orleans this last week, and it turns out he and I decided to split it, and he gave a beautiful talk on NMO spectrum disorders, and just blew. Most of the people in the room were from LSU, Tulane, or Auctioner. They all know him, but he's an extraordinary fellow, and for that reason, I asked him to present probably the most complex case of the evening. So, Alex Cruz.
Hi, can you hear me?
Yes, we can.
Well, thank you for the introduction. Okay, I'm gonna try to be quick since I know I just have like a few minutes, but it is a complex presentation, but actually we're just gonna be going over some neuroanatomy basically. So I'm gonna be presenting a variant of the Hyman-Wilczewski in a patient with MS that also had an oculopalatal tremor. Okay, so next. Okay, so just a little background. We know that multiple sclerosis can present with different visual symptoms. It can affect the afferent pathway, it can affect the efferent pathway, and it's kind of our job to use all of these tools that I'm showing here in my slide to identify all of it. So as you can see, the list is kind of big. So the next slide, please. So again, this is just to give you an example of everything that can go wrong with an inflammatory lesion or demyelinating lesion in a patient with MS. Again, I'm not going to go through each one of them. Just want to put this here for reference. Next slide. Okay, so what's our objective? So our objective here is to kind of describe a patient that presented with both oculopalatal tremor and a variant of a Hyman-Wilczewski, which is kind of unusual to have this of this in the same patient, but this is actually a great patient that we were able to illustrate with MRI and kind of explain what was going on. And we'll use this patient to go over these visual pathways.
Mm-hmm. In fact, Alex, this is the first known patient ever to actually present with what we believe to be features of both.
Yes. Okay, next. Okay, so now going to our patient. Our patient is a 72-year-old Caucasian woman. She was initially diagnosed with multiple sclerosis when she was 61, back in 2007. She had had like onset of symptoms even before that when she was 26. She was mainly having paresthesias initially. It was not in any treatment for a while. Until even when she was diagnosed, she chose to delay disease-modifying therapy for some time, she was basically treating her two of her relapses with steroids, and kind of she chose not to be in a DMT for some time. Eventually, she was starting on Copaxone, I believe. And she was stable. She went a couple of years without significant relapses. However, most of her MS was manifested mainly in her vision. She had a binocular double vision in 2007. Before that, there was history of maybe an optic neuritis. We really didn't have access to this record, but on her exam, she actually her vision. She was doing well. I believe it was 20/40. I will present that later. But it wasn't until 2016 when she went cataract surgery in both eyes. And after this, she started to notice that her double vision was getting worse, and more than that, she started experiencing dizziness, vertigo. It seems when we were getting deeply into kind of try to scrutinize this, it seems that the dizziness and vertigo that she was describing was being triggered by her vision symptoms. In 2007, this was still before she came to us, she was diagnosed as having a vertical nystagmus. She saw, I believe there was like 6 different providers, I think all neurologists. Basically, they couldn't offer a treatment for her. She kept going from physician to physician because she describes this year to be like the worst year of her life. Her vision, it was so bad that she actually had to patch her left eye to be able to function. She patched her left eye because this was the eye that she was noticing that it was giving her like this kind of illusion of movement, which eventually when she came to us, I mean, she was describing oscillopsia in just that one eye. And next slide. So she came to us on her exam. Just we're gonna just for sake of time, we're gonna do the pertinence. So she had a monocular vertical pendular nystagmus only on the left eye. This nystagmus was a very low amplitude, and it was coarse, as you would expect with someone with a Hyman-Blitchowski syndrome. More than that, when we were doing our exam, we actually were able to see something that actually the patient had not noticed before. She had actually a palatal tremor. It was asymptomatic. She had really no problems whatsoever that she could think of, and there was no click to it, because I know normally a lot of this palatal tremor will come with this click that will be obvious to the patient and then to us, but it seemed that it's something that had been there, not bothering her, and it had been missed in previous exams by other providers. Our MRI, I'm going to be showing it in a little bit, but it showed a lesion that was localized in the right ventral medulla, right where the inferior olivary nucleus is localized. And if we can go to the next. And this is a video, we can play it. Basically what we're showing, we're seeing here is vertical pendular nystagmus only in the left eye. And with Hyman-Blitchowski, it can be bilateral, but it's important to know that when this occurs, one eye might be very obvious, as it is with her, but the other one might be very subtle, and that's why it's very important to try to identify a very subtle nystagmus by the use of ophthalmoscope. I mean, the way to do it is just do you grab your ophthalmoscope, you try to look in the back of the eye, just try to basically localize a structure, is it a vessel or the optic nerve, and then basically just see if there's any nystagmus or like subtle nystagmus, and that's kind of the best way to do it. Well, in her, it wasn't there, so it was just localized to the left eye.
Hey, Alex, if I could interrupt for just 1 second, I see that Kristen Galetta just got on and is the chief resident at the Partners Program at Mass General and the Brigham at Harvard, but I had to call her out because her father, Steve Galetta, is one of 2 reasons why I became a neuro-ophthalmologist with an MSologist, because he's the most prolific teacher, educator, and writer ever. I'm not just saying that because you're on the line, Kristen, but anyway, I hope you're following in your dad's footsteps. And if you decide to wake up in a cold sweat and come to Austin, you're in. We would take you tomorrow, yesterday. Anyway, she's on the line. I had to do that. Sorry. Keep going, Alex.
Okay, we can go to the next slide. Okay, and this is that palatal tremor. As you can see here, it's very symmetric, maybe a little bit more in the left, but you can definitely something that is very notorious when you look at these patients.
By the way, we apologize for the sampling rate. Usually these are going to be running like 60 hertz, but obviously something was lost in translation when we sent it.
Elliot.
Yeah, to the MS Society.
Okay, and again, it's important to know that if there was no click nor any type of noise associated with this. And next. Okay, so what is this? The Hyman-Wilczewski is normally it happens in the context of having like severe vision loss in one eye. Normally the vision acuity should be like 20 to 100. Our patient was 20/40. So actually she didn't have any vision loss. However, she did have like this severe oscillopsia, which was basically creating this retinal slip. And what that is basically is just misaligning the light perception into the macula, and that way it was creating like a severe, even though it was vision loss, it was a great vision disturbance that probably was kind of the precursor of this phenomenon. Now, moreover, she had an oculopalatal tremor, which was small, coarse, and really asymptomatic, and we could localize this to the inferior olive nucleus lesion that I'm going to show you in a little bit. And again, we're calling this a variant of Hyman-Wilczewski just because it was just present in this eye, in the left eye, in the setting of oculopalatal tremor in this patient with MS. And on the next slide. So why this happened, or why the oculopalatal tremor happened? So that one we know that is a lesion in the Guillain-Molleret triangle, which basically it's the triangle that is formed by the dentate nucleus in the cerebellum. Then this projects up superiorly through the cerebellar peduncle up to the rostral midbrain, right where the red nucleus is, and right there it kind of descends all the way to the inferior olivary nucleus. Now, this pathway, what is doing is basically sending inhibition to the inferior olivary nucleus. So when you have a lesion, as we suspect, like as we know our patient had, you're basically losing this inhibition, and the olivary nucleus is free to fire and is hypersensitive. Now, the Hyman-Wilczewski, it's a little bit less understood, but again, it's normally always in the presence of severe vision loss. And basically, what we think is maybe a lesion and convergence of the pathways of the brainstem and the cerebellum. Next. So this is just a diagram where we can see this triangle. You can see, so the green arrows basically are showing just, that's the retinal pathway. You can see the light going through the retina, going down to the midbrain, and then going down. And while it's going down, you can see how both of these pathways, the retinal pathway with the Guillain-Molleret triangle, converge right before into the inferior olivary hypertrophy. And we have marked there with a red X where we think our patient had this lesion that potentially explaining her symptoms. Next. And you can see right there, just like the eye, that's just the oscillopsia, the vertical nystagmus. Well, the vertical nystagmus causing the oscillopsia, causing this retinal slip that is probably the cause of this Hyman-Wilczewski. Next.
And for those listening, just remember when you have nystagmus, which is horizontal, vertical, or elliptical, objects of interest that should be stabilized on the fovea, particularly the central portion in the foveola, that if you have these motions horizontally or vertically, you're going to have retinal slip, which will degrade visual acuity. If you had nystagmus that was pure rotary along the line of sight, then there wouldn't be any retinal slip. So this is one of the profound problems with acquired pendular nystagmus, especially, whereas in childhood, where you have congenital pendular, they have, if you look at the recordings very carefully, during the waveform, there's about a 70 millisecond, what we call breaking saccade, and they do all of their foveation in that 70 milliseconds, and their brain suppresses the rest of the image motion. So they have no oscillopsia. It's hard to believe if you look at their eyes, but they don't. Okay, Alex.
Okay, yeah. Next. Next slide. Okay, so this is the MRI. Sorry about the quality, but you can see there the hypertrophy, this T2 hyperintense lesion right there in the medulla, the ventral medulla, right where the inferior olivary nucleus is, and that's explaining the oculopalatal tremor, and potentially also the Hyman-Bilchowski. So what do they do? So the way these pathways, or the job of this pathway basically is, so with our stereo vision, basically what happens, like each eye has like a slightly different vision of in each eye, and this pathway basically just refine and these two images into one high definition image. And this depends of coordination between the inferior olivary nucleus, and of course the cerebellum. We depend on it with for the accuracy, for the metrics of our eye movements, and of course the smooth pursuits, and stabilizing also the retina for foveation, which is very important. So our dual hypothesis here is why this is happening. Well, first, of course, when you have like, we have this lesion here in the ventral medulla, which is basically canceling the inhibition of the inferior olivary nucleus. Then this is unopposed, and it's hypersensitive and is firing. Then you have, because of this increase of firing rate by the olivary nucleus, you're going to have cerebellar augmentation because of this. And of course, our hypothesis is because basically the lesion here was affecting both of this pathway, the retinal pathway, and the Guillain-Mollaret triangle. So what did we do for these patients? So we started gabapentin 100 milligrams 2 times a day, and we titrated up. Her tremor actually, this didn't have any effect on the tremor, but actually her tremor was not bothering her and was not causing any trouble. But the oscillopsia actually resolved when we got up to 600 milligrams 3 times a day. This was a significant change from our patient, because just to remind you, she came to us because she was miserable and saying that she has had like, she was very depressed, very anxious, just because she was not able to function and had to be wearing a patch all day. So the fact that we were able to help her with this, it was really significant for her. So far she has she has been and continues to be in gabapentin 203 times a day with really no issues as far as with her vision, and she's able to do pretty much everything with her vision. One thing that has been reported is sometimes patients like this will tend to have some basically the gabapentin or whichever medication you use. They're sensitized to it and it stops working. So that's why sometimes our plan with her is to probably transition to an oscillating therapy, which basically kind of means if try a different agent and be oscillating between 1 or 2, or maybe a combination of 2. And if something's if she starts getting symptomatic, you can always kind of try to wean one off and titrate one off, and this normally kind of helps with patient symptoms. And I think that's it. I don't know if anybody has any other questions, any comments.
I think that's a lovely presentation. I did forget to mention to Kristen Galletta that actually co-authors on this paper include David Z of Lee and Z, the Neurology of Eye Movements in Baltimore at Hopkins, but also includes Kristen's dad, Steve Galletta. He's already seen this case, and so we've had nice corroboration from some of the other giants that are still with us walking the earth. So it's a really very interesting story.
Okay, well, thank you so much, everyone.
Any other questions? I think what we're going to do is, in the interest of time, it's now 6:21, so we're 6 minutes over. Teresa and I had 2 cases. I think what we'll do, Doris, is move our 2 cases to one of the regular second Tuesdays of the month. We'll see where we have time, and we'll always be prepared to sort of put those in. I think they're both very important, particularly with respect to not rare, not uncommon problems we have in MS. The last that I was going to present has to do with issues of pelvic floor and some interesting patients with vaginal sexual problems that we were able actually to make actionable and to help those patients and abolish what was some very strange syndromes that occur in MS. And very important case, given the fact that if you take men with erectile dysfunction out of the equation, the only number you need to know about ascertainment is 90. 90% of the patients don't ask or tell their physicians, and 90% of physicians don't ask their patients about sexual dysfunction. I'm talking specifically about the cohort.
Wait a minute, Elliot, that was part of my presentation.
Yeah, well, both of ours.
Yeah.
Yeah, it's both. Okay, so Doris, I think with that and given the time, I think we'll conclude this webinar for the Fast and Furious cases. I want to thank the presenters. They were really just superb, and shame on me for thinking we were really going to get through 6 in an hour and a half. But okay, not as bad as I thought.
Elliot, you are the eternal optimist.
I know.
All right, so thank you to everyone, and we did record this presentation, and I will be posting it on our website within the next couple of days, and then we will pick up again in September. The regularly scheduled second Tuesday of the month webinar in September would have landed the week of ECTRIMS, so we will actually be pushing that back a couple of weeks. I will send that information out this week. Didn't want to do it before today and confuse folks, but after that we'll be back to our regular Tuesday schedule. So if you don't have these on your calendar, let me know so I can send you the reoccurring calendar invites. And
Yes.
that is
Thanks,
it.
Doris.
Yeah, and last
Thank
point
you, Doris.
that I'd like to make is to everybody, don't forget to check and look toward Neurology N2 as a resource for those of us who are interested in this field. It's really going through a renaissance. We, as a derivative of this program, the webinars, we've published now 4 really outstanding cases in the section entitled From the National Multiple Sclerosis Case Conference Proceedings. And you'll be happy to know that all 5 authors or fellows that were invited to submit new papers by August 10th this month, all 5 came in on time, some early. So you're going to be seeing 5 additional cases, one of whom is from during her training at the University of Rochester in New York with Andrew Goodman, who's been on this call as well. So I couldn't be more proud of the alliance between the society, the fellows they're training, and the outstanding faculty who have given up their time and expertise. So it's been very, very special. I feel very privileged to be involved. Thanks, Doris.
Thank you. Good night, everyone.
Good night. Thank you.